this morning, uh, we're going to tie up scanning views, different windows, the different structures you see in the windows, and the Dopplers. So we're going to tie up everything this morning. Um, so most of us, when we start our study, we start with the power stirring long axis view, and again, to get the power stirring long axis view, transducer is in the third or fourth left intercostal space, and the marker points towards the right shoulder, and you get an image looking like this. Just to remind you, this is your posterior wall. This is the septum, LV cavity. The mitral valve is right here, the anterior leaflet, posterior leaflet. This is your left atrium. Your aortic valve is right here. You have your ascending aorta. This is your right ventricle. Again, your transducer or your probe is right up here. The chest wall is right here. And then below the chest wall, you'll have your pericardium, then the RV wall. This is the RV cavity, your ventricular septum. Your descending aorta is someplace right down there. So just putting it together. Um, so this is we have not started M mode as yet, so we are going to not mention this. All right, so this is M mode. Um, okay, so these series are M mode, so we're gonna not go over them because the M mode is we have a separate lecture where we're gonna go over M mode. Okay, so now the M mode. So this is our parasternal long axis, and we have our color flow. So again, your transducers at the top. Okay, so you have to know where your transducer is. The transducer is right up here. Okay, then below the transducer, you have the chest wall, all that sort of stuff. This is the RV cavity, ventricular septum, LV cavity, posterior wall. So now you have your color flow. Remember, color flow is a form of pulse wave Doppler. Flow towards the transducer is going to be in shades of red, and flow away from the transducer is going to be in shades of blue. So put our color across the aortic valve. Okay, so anything that's going up into the aorta would be red, anything going back would be blue. When we do our color flow, we're looking for regurgitation or any abnormal flow. So that will give you an indication if there's any abnormal flow. So we usually put the color flow across the different valves, or if we suspect that the patient has a ventricular septal defect, we do the same. We put the color. Um, you have to develop a system for yourself, but what we recommend is using the color first to identify if there's any abnormality, and then you can get some objectivity of that abnormality by doing your pulse wave and your continuous wave. So it's your color flow. So again, you're going to put your color flow across the different valves, looking for regurgitation or any abnormal flow. So it's now across the mitral valve, okay? So, and you have to remember the principles of color flow. Flow towards the transducer is red, flow away from the transducer is in different shades of blue. Again, your parasternal long axis. This is your descending aorta right there. This is the posterior wall. And remember that your posterior wall, just below the posterior, this is the posterior wall. Below the posterior wall, you have the pericardium, which lines the heart. This is the LV cavity, ventricular septum. This is your RV cavity. You have the RV wall and then the chest wall. Your aortic valve is right there, the ascending aorta. This is your left atrium. This is the mitral valve, the anterior leaflet and the posterior leaflet, and descending aorta. And you have to remember how you get your parasternal long axis view, third or fourth left intercostal space, and the marker points towards the right shoulder. Okay, and we're going to show you how to do your measurements. Okay. All right, so at the tip of the mitral leaflet, you measure the septum, thickness of the septum. You measure the LV cavity size in diastole, and you're going to measure your posterior wall. The other measurement you should take in diastole is the aortic root. So you should measure the aortic root, and the aortic root is from leading edge to the leading edge, and you have to make a note of where you're doing the root. Is it from sinus to sinus or the sinotubular junction? So it's important to make a note of that. Okay, this is you measure the RV, this RV size. Um, the well, we haven't done right side. So when we start right side of right heart, then we'll go over all these measurements of the right heart. But you know, we can measure the right ventricular flow tract by doing this measurement. So don't worry about that yet. Again, you can see it's in motion. The aortic valve is opening and closing. The mitral valve is opening and closing. The aortic valve opens in systole, mitral valve opens in diastole. Okay. So this measurement again should be done in diastole. So you measure your left atrium. Left atrium measurement is from leading edge to leading edge, and it's a systolic measurement. Okay. If you want to, when you're doing your measurements, you should always zoom to do your measurements, because the error that you create is going to be less in when you zoom it. So should always do your measurements when you zoom it. Or if you're looking for any any abnormality and you want a better view, you zoom it. So okay, you also measure the LVOT diameter. So it's a couple millimeters in front of the aortic valve, and that's done in systole. Okay, it's a systolic measurement, so you must always have your ECG someplace to tell you when it's systole. So this is your LVOT diameter. Okay, so again, if you're not sure what's going on, you put your color on and you look at the valve. It's very important to look at the valves, because one of the things that we report on when we do echo is regurgitation, any abnormal flow. We usually report on that. So you have to put your color flow Doppler across all the valves. The main thing you're looking for is regurgitation. Okay. Then you measure LV in systole. So your ECG is on the bottom. Systole is, we can use the end of the T wave. So the marker is at the end of the T wave. In systole, from the tip of the mitral leaflet, from the septum to the posterior wall. In systole, your aortic valve is open and your mitral valve is closed. Just a good check on it. Okay. So this is your RV inflow view. RV inflow view. To get that, you the angle of your transducer, you just tilt it towards the left axilla. Okay, and this is your RV inflow view. The posterior leaflet is right there. The anterior leaflet is there. This is a tricuspid valve, of course. So the tricuspid valve is right there. This is your right atrium and your right ventricle. Okay, right atrium below, right ventricle above. This is the posterior leaflet of the tricuspid valve, the anterior leaflet. And of course, you've got to put color. This is a short axis at the level of the aorta. Okay. Short axis at the level of the aorta. Your transducer is right there. You have the color going. So this is your right atrium. Tricuspid valve is right there. Right ventricle is right there. So you have this color going up there. So this is flow from your inferior vena cava into the right atrium. It's going in this direction. That's why it's different shades of red. Okay, flow towards the transducer is red. Flow away from the transducer is blue, or different shades of blue. Okay, so short axis at the level of the aorta. Aorta is right there. Cursor is right there. We say that over here you have the tricuspid valve. This is the cursor. Your sample volume is right there. Transducer probe is there. We get this flow below the baseline. Your ECG is right there. If you look at it, it's a systolic flow from the end of from the beginning of the QRS to the end of the T wave, beginning of the QRS to the end of the T wave, beginning of QRS, end of T wave. So you have this systolic flow below the baseline, and it's across the tricuspid valve. So if the envelope is below the baseline, that means the flow is away from the transducer. Okay, the flow is away from the transducer. It's across the tricuspid valve, so this is tricuspid regurgitation, tricuspid regurgitation. Okay, again, so tricuspid regurgitation, the flow is below the baseline because it's moving from the right ventricle across the tricuspid valve into the right atrium and moving away from the transducer. Right, so, and that is C doubler. C doubler because the velocity is more than 1.5 to 2 meters per second. So you couldn't use pulse wave Doppler. It is C doubler. All right. So when we talk about regurgitation, the velocity is usually greater than 1.5 to 2 meters per second. So you would use C doubler as opposed to P doubler. Again, short axis at the level of the aorta. Tricuspid valve is there. Your pulmonary valve is right there. And you must always look to see if you have 3 leaflets. Okay? It, how are you going to do that to determine if there are 3 leaflets? You have to wait until the valve opens, because when the valve closes, a raphe may look like a completed cusp. But when it opens, you can see the 3 cusps clearly. So you have the tricuspid valve over there, your pulmonary valve right there. This is the septal leaflet, and your anterior leaflet right there, tricuspid valve. You put color across everything because you want to see if there's any regurgitation across the aortic valve. So you put color. You put color across all the valves. Okay. So you need to develop a routine that you use. So you put color across the pulmonary valve, and if you look closely, you can see there's a little hue right there. There's a little, if you look closer, there's okay, we saw it, you saw the message. Well, let me see if we can go back. We missed it a little bit, but essentially, oh, we just missed it. Let me go back. Okay, so this is, you can see that, so you have to look for these subtle color phenomenon. So this is a flow which is going towards the transducer. Transducer probe is right there. This is a varying shade of red. So it's not completely red, but it's varying shade of red, which suggests that the flow is going towards the transducer. It's across the pulmonary valve. Okay, it's across the pulmonary valve. And if you look at your marker right down here, it's actually in diastole. So your diastole is from the end of the T wave to the QRS. So we have a diastolic flow across the pulmonary valve. This is what we call pulmonic insufficiency. So that is how you use your color flow to identify abnormal flow. And then you can do objective study on that flow using your pulse wave and your continuous wave. So this is what your PI looks like, and you have to look for it. Sometimes they're very subtle. Okay. So after you see that, then you put your cursor across the pulmonic valve. The sample volume is right there, and you do your you do your you can do your PW first. Okay, you should do your PW first, and then you can go on to CW after uh, you finish your PW. But there is a diastolic flow, and that's what they're measuring. Again, your ECG, you always have to revert to your ECG because is the flow is either systolic or diastolic. And there's a little diastolic flow, which is your pulmonic insufficiency, pulmonic regurgitation. So you can identify the abnormal flow with the color flow, and then you can, proper do more uh, evaluation on the flow using your pulse wave and continuous wave. So again, short axis at the level of the aorta, the pulmonic valve is over there. Your cursor is across the pulmonic valve. The sample volume is right there. And you just put your PW on. Press the PW button, and you see that there's a flow below the baseline. There is this repetitive flow below the baseline. And when you look at your ECG, it is systolic because it's from the onset of the QRS to the end of the T wave, onset of QRS, end of the T wave, onset of QRS, T wave. So you have this systolic flow moving away from the transducer because it's below the baseline. Okay, transducer is right there. So we're talking about a flow which is moving from the right ventricle across the pulmonary valve into the pulmonary trunk. This is the normal flow of blood. Remember that blood flows from the right ventricle across the right ventricular flow tract, across the pulmonary valve into the pulmonary trunk. This is now deoxygenated blood that is going to go to the lungs to get oxygen. So this is our normal pulmonary flow. And we usually use PW for the measurements. PW. Because it's a relatively low flow situation. So once you have flow below or velocities below 1.5 to 2 meters per second, you use pulse wave Doppler. So your flow across the pulmonary valve, uh, unless of course there is obstruction. And so, and then we trace what we call planimetry. We trace the outer border of the flow, and so we do planimetry of um, the envelope. And when you do planimetry of the envelope, you're going to get a number of things. You're going to get the peak velocity, okay? Because again, time is on the horizontal axis, velocity is on the vertical axis. So you'll get your peak velocity, which is down there. You also get a mean velocity, you get a peak gradient, you get a mean gradient, and then very important, you get what we call this VTI is your velocity time integral, because again, time is on the horizontal axis, velocity is on the vertical axis, and when you integrate both, you get your velocity time integral. But you have to trace the border of the envelope to get that. Okay. Again, you're going to do color flow of everything. So you put the color flow across the tricuspid valve, okay? Put your color flow across the tricuspid valve. So you put the tricuspid, in this view, short axis at the level of the aorta. You're going to put your color flow across tricuspid valve, the aortic valve, and the pulmonary valve. And you also put your pulse wave Doppler. So you not only do color flow, but you put your pulse wave Doppler, and if necessary, you do your continuous wave Doppler. So if you put your pulse wave Doppler and there's tricuspid regurgitation, then you'll go on to your CW, continuous wave Doppler, because more than likely you're going to get a high flow situation. So this is short axis at the level of the mitral valve. So to get that, you're going to clockwise rotate the transducer 1 or 2 o'clock position. The angle of your transducer, it's not gonna be all the way down, it's gonna be midway. Okay, so you need to develop a strategy how you're going to do this. So if you want to start at the level of the aorta, short axis level of the aorta, the angle of the transducer should be downwards towards the feet. Okay, and then you adjust your transducers to get the short axis to the level of the aorta. That's what we just did. So if you move the angle up a little bit, then you'll get short axis at the mitral valve. The anterior leaflet is on top, posterior leaflet is below, and we went over the walls. The anterior wall is right there, your inferior wall is right there, the lateral wall, and your septum. We further divide the lateral wall into anterior lateral wall, inferior lateral wall, further divide the septum, anterior septum, and inferior septum. You have to know those, okay? You have to know the regional wall or the segmental walls. Very important. Okay, then to move from the base of the heart where you have the mitral valve, you're going to move the angle of the transducer upwards a little bit. So this is at the mid cavity level. The papillary muscles are going to be inserted at this level. The anterior lateral papillary muscle is over here. So your anterior lateral papillary muscle is over here, and your posterior medial papillary muscle right there. Anterior lateral papillary muscle there, posterior medial papillary muscle. This is short axis at the level of the mid cavity. The anterior wall is on top, the inferior wall is there. This is the lateral wall, the septum. But we further divide the lateral wall into an anterior lateral wall and an inferior lateral wall. The septum we divide an anterior septum and an inferior septum. Okay, you have, if you don't know to know, if you don't know how to label the walls, you shouldn't be doing echo. So it's something that you have. These are stuff that we went over before, so you should know the walls. This is at the level of the apex now. So you move the angle of the transducer further upwards, and this is the apex of the LV cavity. So the anterior wall, so the apex only have 4 segments. So the anterior wall is on top, the anterior wall is on top, inferior wall, the lateral wall, and the septum. So the apex have only 4 segments. Okay. So if you need to get additional information on any views, then you do that. You need to have a routine where you move from one step to the next. But the important thing is to make a diagnosis. So if you see something and you need additional views, then you do that. So this is our apical 4-chamber view. To get your apical 4-chamber view, you find the apex of the heart. the PMI, the point of maximal intensity, and you just put your transducer probe there. The marker should be about the 4 or 5 o'clock position, or you can use the mid-clavicular line where it intersects the 5th intercostal space. That's usually a good marker. And then you put your probe there. The marker on the probe should be 4 or 5 o'clock position. If the patient's heart is enlarged, you're going to feel for the PMI, the point of maximal intensity. You're going to feel for the apex, and then you put your probe where you feel the point of maximal intensity. Again, the marker is going to be the 4 or 5 o'clock position, and your heart should be standing straight up like that. Okay. Again, your transducer probe is there, the chest wall. Then you now come to the heart. This is the LV cavity. LV cavity is right here. This is the lateral wall, the apex. This is our septum, the mitral valve, the anterior leaflet, the posterior leaflet. This is your left atrium. And on either side of the left atrium, you're going to have your pulmonary veins. Okay, this is the right, this is the left. These are the superior pulmonary veins. Your descending aorta is right there. Your atrial septum, this is the right atrium, tricuspid valve, the septal leaflet, the anterior leaflet. This is the right ventricle, okay? And this is the right ventricular wall. So you not only have to know how to get it, but you have to know how to label the different structures. So that's your apical 4-chamber view. Again, we put color across all the structures. We're looking for regurgitation. Your ECG is a part of the study. So we'll put a color across the mitral valve, and we'll put a color across the aortic valve. We're looking for pathology. We're looking for regurgitation. Again, flow towards the transducer is going to be in varying shades of red, and then flow away from the transducer, varying shades of blue. And then we'll do the same thing. We'll put our color flow across the tricuspid valve. The main purpose of our color flow Doppler is for identification. Okay, so you're going to identify the pathology, and then to further characterize and get objective data, then you do your P doubler and C doubler. Okay, so this is our 5-chamber view. To get the 5-chamber view, the angle of the transducer, you tilt it downwards a little bit. Very, very minuscule movement. You open the aortic valve is right there. You're looking at the flow across your left ventricular flow tract and aorta. Again, remember that in systole, blood is going to flow from the LV cavity across the left ventricular flow tract, across the aortic valve into the aorta. Flow towards the transducer, varying shades of red. Flow away from the transducer, varying shades of blue. Okay, so our cursor is now cutting across the LV cavity, across the left atrium. The sample volume is right at the tip of the mitral leaflet, and you're going to press your P doubler, pulse wave Doppler. And by doing that, you're going to get the mitral inflow. Mitral inflow. Your ECG is on the bottom. Again, systole is from the beginning of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So we see that we get this diastolic flow, repeated diastolic flow. And this is our E velocity. This is our A velocity. Okay? Um, so our E velocity is when the valve first opens, there's a suction, there's a rapid movement of blood from the left atrium into the left ventricle because of the pressure difference in the cavity. And then at the end of our E velocity, then the atrium contracts and pumps an additional amount of blood in the ventricle. So both of these flows have velocities. Okay. Mitral inflow is measured using P doubler. Okay. This is, we just change the sweep speed. There's still mitral inflow, and we'll tell you when you need to do that. Okay. So again, you can you can do C doubler across the mitral inflow, but it should be done with P doubler because you can have obstruction. You can have obstruction across the mitral valve and you get increase in velocity. So in that case, you would use C doubler, but you should always start with your P doubler. So mitral inflow is usually a pulse wave Doppler measurement. Okay. And when your cursor is across a mitral valve, you can also pick up mitral regurgitation. There's a tinge of mitral regurgitation, a very, very small amount, extremely small amount. You can see that there's a little bit of envelope here below the baseline. It's repetitive. It's systolic. It's from the onset of the QRS to the T wave. There's a little bit. Your cursor is right here. Your transducer probe is there. There's a small amount of flow going from the LV across the mitral valve into the left atrium. It's below the baseline because the flow is away from the transducer. So this would be mitral regurgitation. It's very, very tiny. Okay? And we'll show you later on how to quantify these flows. But when the envelope is very faint, and the density of the envelope helps us to determine the severity of the regurgitation. It's very, very faint, so it suggests that you have a trace. It's very small. So, okay. Um, let's All right. So now we're measuring. So if you look closely at the cursor is right there. The sample volume is right there. This is our left atrium. We have one pulmonary valve there, and we have another one over here. This is your right superior, and you press. This is a tissue Doppler. You're sorry. This is not tissue. This is pulse wave Doppler. Okay, you're measuring pulmonary flow. Remember that in systole, you're going to have flow from the pulmonary vein into the left atrium. In diastole, you're going to have flow from the pulmonary vein into the left atrium. But when the atrium contracts, you're going to have blood flow in the opposite direction. So if you look closely, you can see that there is a systolic flow and there's a diastolic flow. It's not very clear. And then there's an atrial flow reversal. Sometimes it's difficult to get your pulmonary vein flow, but you usually get a systolic component, a diastolic component, and an atrial flow reversal. It's a pulse wave Doppler measurement. The flow systole and diastole is usually above the baseline. Your probe is right there. The pulmonary vein is there. The blood is flowing into the left atrium. The blood is flowing from the pulmonary vein into the left atrium. It's going towards the transducer. That's why it's above the baseline. But when the atrium contracts, in atrial systole, when the atrium contracts, the blood is pumped backwards. So it's moving away from the transducer. So when you have, you're going to have a flow below the baseline. Okay. So everything in echo means something. Nothing is magical. So you have to explain it. Okay. Now this is supposed to be the apical 4-chamber view on top. I'm not sure why uh, it didn't come up, but when at the mitral annulus, you put your cursor across the mitral annulus. The sample volume is right at the medial mitral annulus, and you press. This is tissue Doppler imaging. What you're doing, you're looking at the movement of the tissue. Remember what we showed you in systole, the base of the heart moves up. In diastole, the base of the heart moves down. Okay, your transducer is right there. So if the base of the heart moves up, in systole, it's moving towards the transducer or the probe. So this is our systolic flow, or so-called S prime. And then in diastole, the base of the heart moves down. It moves away from the transducer. So you'll get an E prime and an A prime. Okay, so this is our systolic flow. And then we have two diastolic components, E prime and an A prime. This is tissue Doppler imaging. It's a pulse wave Doppler. Tissue Doppler imaging is a pulse wave Doppler. We're just looking at the movement of the mitral annulus. It gives us information on the systolic function because the S prime tells us about the systolic function, and then our E prime and A prime tells us about diastolic function. So those are important measurements, very important measurements, and we do them on all studies. Okay, so we did it in the medial, now you do it in the lateral. And so the lateral mitral annulus, this is your cursor, the sample volume is at the annulus, and you just press your TDI button, tissue Doppler imaging button. It's a form of pulse wave Doppler. In systole, the base of the heart moves up. In diastole, you have two components, but they move down, they move away from the probe or the transducer. The reason why we do medial and lateral mitral annular velocity is because even though the contour is the same, you can get additional information by doing both. Usually the lateral annulus will give you a larger E prime velocity. Usually the lateral annulus gives you a larger E prime velocity. Okay, again, so we put color across everything. So this is our aortic valve, 5-chamber view, and we open the valve and we put color. Again, if there's aortic insufficiency or aortic regurgitation, you can see it. If there's aortic stenosis, you'll see evidence of turbulence. So we usually use color to identify what's going on and then to further characterize what's the abnormality. Then we'll do PW and CW if we're going to do measurements. Okay. Okay. So our cursor is right there. It's cutting across the LV cavity. Your left ventricular flow tract is right there. The aortic valve is right there. And we measure our left ventricular flow tract velocity. Okay. So this should be a little further down. You can measure velocity in the mid cavity, but if you're going to measure left ventricular flow tract velocity, should be the sample volume should be a little lower, and you'll get these envelopes. These are systolic envelopes. Okay, you can see systole is from the onset of the QRS to the T wave. So you get these repeated systolic envelopes because blood is flowing from the LV cavity across the left ventricular flow tract, across the aortic valve into the aorta. It's moving away from the transducer. So the flow is below the baseline. Okay. Again, your LVOT envelope. And you have to plane, you have to do planimetry. You have to do planimetry of that flow. So all envelopes that you get, you should do planimetry of it. Okay, so again, LVOT, it's a pulse wave Doppler, okay, because you have low flow velocity, so it's a pulse wave Doppler uh, measurement, okay, okay, and so you're going to do planimetry of the envelope, okay, you just trace around it, okay, remember time is on the horizontal axis, velocity is on the vertical axis, so you're going to get your LVOT maximum velocity, in this case it's 0.97. Usually the LVOT maximum velocity is about 1 meter per second or something close to that. You can get the mean velocity, you can get the maximum gradient and the mean gradient. Importantly, you can also get the VTI, velocity time integral, where you have to do planimetry of the envelope and you're going to integrate the time and the velocity, and that's why you get the velocity time integral, the area under the curve, so to speak. Okay, then you put your sample volume into the aortic valve because you want to get the flow across the aortic valve, and a lot of time you'll have aortic stenosis, and that is when you want to put your sample volume into the aortic valve. Then you'll get a very high velocity, and you want to measure that using continuous wave Doppler. So once you put it into the aortic valve, you probably should switch to CW, and you're going to do the same thing. You're going to do planimetry of the envelope. You're going to draw around the surface of the outer borders of the envelope. You're going to again get your maximum velocity, mean velocity, the maximum gradient, mean gradient, and importantly, the VTI, velocity time integral. Okay, so you put your color across the tricuspid valve. Again, if there is any TR, any abnormal flow, you'll get an indication, and then you can move to your pulse wave Doppler and your continuous wave Doppler. You need to develop uh, a system where you do your studies. Everything should flow. All right. So if you look closely, you get these. So again, you expect, well, you should start with P Doppler. So, well, you start with your continuous, your color flow Doppler to identify if there is any TR. Then you move to P Doppler and then C Doppler. Usually when you have any type of regurgitation, it's going to be a high flow, high velocity situation. So C Doppler is appropriate for those uh, abnormality. Again, you see that there is a repetitive flow below the baseline, okay? And when you look at your ECG, it's systolic from the onset of the QRS to the end of the T wave. So you have this systolic flow below the baseline across the tricuspid valve. So therefore, the flow is moving away from the transducer. So it's moving from the RV across the tricuspid valve into the RA. So these are the flows again. This is tricuspid regurgitation. And you can measure the velocity. Again, the velocity is on the vertical axis, time is on the horizontal axis. If you measure the peak of the velocity, you can see it's more than 2 meters per second. That is why you need your continuous wave Doppler. Okay, we haven't done that yet, so we're not going to go into that. Okay. So we haven't done this yet, but you can see that this is your tricuspid. Your tricuspid annular plane is right here, and our cursor is right there, and sample volume is right there. We can not we usually look at the velocity of the lateral tricuspid annular plane, the velocity, basically how much it moves up and down. Again, in systole, this tricuspid annular plane is going to move upwards, okay, towards the transducer, hence it's above the baseline, and we can measure the velocity, okay. In this case, the velocity is 17 centimeters per second. So that's just basically what we did. We just put our cursor there, sample volume at the lateral tricuspid annular plane, and measure the velocity. Um, that. Apical four-chamber view. It's your two-chamber view. So to get your two-chamber view, you're going to counterclockwise the transducer. This is your inferior wall, anterior wall, mitral valve is there, anterior leaflet, and the posterior leaflet. Again, you're going to put color. You put color across all the valves in all the views. You always start with your color flow Doppler. You want to identify any abnormal flow, and then you move to your pulse wave and continuous wave Doppler. Remember that color flow is a form of your pulse wave Doppler. So to get the apical three-chamber view further counterclockwise rotation, this is your inferior lateral wall. This is your anterior septum. Okay, your aortic valve is right there, ascending aorta right there. It's your left atrium. So you put color in all when you know whatever view you get, you put your color. You want to identify if there's any valvular pathology. Okay, so you have to develop a system how you do your study so you don't miss anything. Again, cross the left ventricular flow track, put your color, see if there's any aortic insufficiency or even aortic stenosis where you get turbulence. So in your subcostal view, so you know you're going just below the xiphoid process, and you manipulate your transducer, and this is the liver over here, the right side of the heart, left side of the heart. This is the ventricular septum, which divides the right ventricle from the left ventricle. Atrial septum, where you have the right atrium and your left atrium. The inferior vena cava is going to drain into the right atrium. Okay, so this is a subcostal view. Very important view to look if there's any septal defect, ventricular, atrial, or if there's any pericardial effusion as well. Okay, subcostal view. And again, you put color. You want to see if there's any abnormal flow across the ventricular septum, because you can pick up ventricular septal defect. And you'll do the same thing for the atrium, see if there's any atrial septal defect. You can also put the color across the valves, because that might be the only view that you'll see regurgitation. So you put it across the atrial septum, looking for atrial septal defect. So again, your color flow will identify pathology, and then you can further evaluate the pathology using pulse wave or continuous wave. Okay, remember the hepatic veins drain into the inferior vena cava, so you can put your color there. But the important thing is you need to do pulse wave Doppler of your hepatic vein flow. So your study should include, so this is your inferior vena cava right there. Hepatic veins usually drain into the inferior vena cava. You have to do hepatic vein flow, okay? Because if there's any type of tricuspid regurgitation or any pathology, well, whatever it is, you have to measure your hepatic vein. So the hepatic vein is right there, it's draining to the inferior vena cava. So you have to identify it, and okay, so the hepatic vein is right there. Okay, this is your transducer. The hepatic vein usually drains into the inferior vena cava, so the flow is away from the transducer. So you're going to get flow below the baseline. You'll get a systolic component, diastolic component, atrial reversal. So this didn't project very well, but the flow is below the baseline because the blood is moving away from the transducer. Okay. All right, so it's supposed to be not above but below. So yes, this is hepatic vein wasn't open thoroughly. Transducer is right. Your probe is right here. The flow is usually from the hepatic vein into the inferior vena cava. It's moving away from the transducer, so it's below the baseline. All right, so that concludes, we went over a complete study incorporating the different views and C-doubler, well, color flow, pulse wave, and continuous wave. We will do a couple more sessions like this so that you